So, good night, everyone. Thank you for the opportunity to present tonight in the session. My name is Dominic. I'm one of the Part 1 DM Urology residents. All right. And I will be presenting tonight essentially on the formation and the excretion of urine. Essentially, it's a very heavy renal physiology session. Right. We will go through in this session um, the functional units of the kidney, renal blood flow. We will go through the electrolytes, the important electrolytes, sodium, chloride, potassium, right? We will also are going to go through renal angiotensin and aldosterone system, right? As well as a few clinical scenarios or clinical encounters that we do see from time to time. All right. So without further ado, let's start. Let's move. Right. So the kidneys are retroperitoneal organs, and they contain, generally, for the purposes of this talk, they contain three main regions. They contain a cortex, which is the outer layer, a medulla, there's an outer medulla, and an inner medulla, and an inner medulla, all right, which is a small raised projection, right? And within those structures exist the nephrons. So the nephrons are described as the functional units of the kidney, and one kidney contains approximately 1 million nephrons. Each nephron consists of a glomerulus. Glomerulus means small, convoluted, and intertwined mass, in our case, blood vessels, as we're going to talk about, as well as the renal tubule. As I mentioned before, the glomerulus is a capillary network which emerges from an afferent arteriole and is surrounded by a Bowman's capsule. And blood is filtered across the glomerular capillaries into the Bowman space. The tubule comprises the Bowman space, a proximal convoluted tubule, a proximal straight tubule, the loop of Henle, with a thin descending, a thin ascending, and a thick ascending part, a distal convoluted tubule, and the collecting ducts. Right? And each one of these structures we are going to go into detail in the following slides. There are two types of nephrons. There are superficial cortical nephrons, which have their glomeruli in the outer cortex, and these nephrons have relatively short loops of Henle, and they only descend into the outer medulla. There are also juxtamedullary nephrons, which have their glomeruli near the corticomedullary border. The glomeruli of the juxtamedullary nephrons are larger than those of the superficial cortical nephrons, and they accordingly have higher glomerular filtration rates. Another term that we are going to talk about later in the presentation. The juxtamedullary nephrons are characterized by long loops of Henle that descend deep into the inner medulla and the papilla, and they are essential for the concentration of. So, with regards to renal blood flow, right? Just quickly, just by looking at the slide, coming off of the aorta, we have our renal artery, which branches into segmental arteries, into lobar arteries, arcuate, interlobular. Then our afferent arteriole, which then gives us our glomerulus or glomerular capillaries, and leaves us an efferent arteriole, then forms the peritubular capillaries, which are around the tubule, right? Then forms interlobular vein, arcuate vein, interlobar, renal vein, and back to the IVC, right? With regards to renal blood flow specifically, the kidneys receive 20 to 25% of cardiac output, right? And renal blood flow is mainly determined by the pressure gradient between the renal artery and the renal vein, right? And the resistance within the glomerular capillary is determined mainly by the afferent and the efferent arterioles, and that allows independent regulation of renal perfusion and glomerular filtration rate, as we will talk about. With regards to regulation of renal blood flow, just want to touch on these points specifically, briefly, right? Renal blood flow is regulated by the sympathetic nervous system, which is responsible for vasoconstriction of both the afferent and the efferent arterioles, right? It is also affected by angiotensin 2, which is a potent vasoconstrictor of the arterioles, right? It is affected by atrial natriuretic peptide, which is a peptide that dilates the afferent arterioles and constricts the efferent arterioles, right? And it's also controlled by prostaglandins, which are produced locally within the kidney, and these cause vasodilation of both the afferent and the efferent arterioles. Right? So autoregulation is defined as the ability or the intrinsic ability of the kidney to maintain a constant renal blood flow and a glomerular filtration rate despite changes in the mean arterial pressure, right? It is effective over mean arterial pressures of approximately 80 to 200 and below 80 millimeters of mercury, autoregulation falls. Typically, autoregulation occurs by two mechanisms, right, which effectively alter afferent arteriolar resistance, right? There's a myogenic mechanism which is activated by voltage-gated calcium channels in the vascular smooth muscles, and this will increase the intracellular calcium in the afferent arterioles, right, as well as tubuloglomerular feedback, whereby the increased arterial pressures will increase renal blood flow and increase glomerular filtration rate. So let's talk a little bit about glomerular filtration. Glomerular filtration is the first step in urine production. It is the process by which fluid is filtered at the Bowman's capsule, and this fluid is called our ultrafiltrate. Now, the physical characteristics of the glomerular capillary wall determines both the rate and the characteristic of the glomerular filtrate. So, layers of the glomerular capillary wall, we have an endothelium, a basement membrane, and an epithelium. Now, beginning with the endothelial layer has pores about 70 to 100 nanometers in diameter. And these pores are relatively large. So these pores are relatively large, so fluid, solutes, and some proteins can be filtered across the layer of the glomerular capillary barrier, but they are not so large that blood cells can be filtered. After the endothelium, we have a basement membrane, and our basement membrane is further divided into three layers, right? There's a lamina rara interna, which is fused to the endothelium. There's a lamina densa, which is located in the middle, and there's a lamina rara externa, which is fused to the epithelial layer. Right? The multi-layered basement membrane doesn't permit filtration of plasma proteins, and therefore this layer, this basement membrane, is actually the most significant barrier of the glomerular capillary. Then there's an epithelium or epithelial cell layer, which consists of specialized cells called podocytes, which are attached to the basement membrane by foot processes. Between the foot processes are filtration slits, about 25 to 16 nanometers in diameter, which are then bridged by thinner diaphragms. And because of the relatively small size of the filtration slits, the epithelial layer is also considered an important barrier to filtration. But additionally to the layers of the glomerular capillary wall, there's also a negative charge which exists on the glomerular capillary wall itself. Right? These negative charges are present on the endothelium, on the lamina rara interna and the externa, and on the podocytes and the foot processes. And a consequence of these negative charges is that they add an electrostatic component to filtration. Positively charged solutes will be attracted to the negative charges on the barrier and be more readily filtered, whereby negatively charged solutes will be repelled from the negative charges on the barrier. So therefore, how is that important? For small solutes like sodium, potassium, fluoride, and bicarb, the effective charge on the filtration of these solutes are not that important. However, for larger molecules like plasma proteins, the charge is going to affect filtration. So next, let's talk about Starling's forces. All right. Now fluid moves across the fluid movement across the glomerular capillary wall is the process of glomerular filtration, as we spoke about before. And it is driven by these forces called Starling's forces. And now there are four Starling's forces. There are two hydrostatic pressures, one which exists in the capillary blood and then one in the interstitial fluid. And there are two oncotic pressures, one in the capillary blood and one in the interstitial fluid. And in applying these pressures to the glomerular capillaries, there is one modification that we need to keep in mind, is that the oncotic pressure of the Bowman space is zero, right? Because we are assuming that no protein is moving across into the Bowman space, so we take that as zero. Right. So also so let's just look at the equation I have on the left hand side of the screen, and it's a bit more detailed. Right. So there's a KF. KF stands for the filtration coefficient, right, or the hydraulic conductance, right? And there are two factors which contribute to this, right? There is the water permeability per unit area, and there's the total surface area. We have to note that the filtration coefficient for glomerular capillaries is actually more than 100 times greater than for systemic capillaries because of the combination of a higher surface area as well as the higher intrinsic water permeability of the barrier, right? And that means that translates into more fluid can be filtered from glomerular capillaries compared to other capillaries, right? Then next, we have the EGC, or the hydrostatic pressure in the glomerular capillaries. And this is a force that favors filtration. Compared to systemic capillaries, it is about 45 millimeters of mercury, right? In systemic capillaries, hydrostatic pressure tends to fall along the length of the capillary. However, in glomerular capillaries, it's different. It remains constant along the entire length of the capillary. Then we have a PBS, or the hydrostatic pressure in the Bowman space. And this is a force that actually opposes filtration. It's about 10 millimeters of mercury and is fluid and is present in the lumen of the nephron. And then there's a IGC, or oncotic pressure in the glomerular capillary. And this is another force that opposes filtration. This is determined by the protein concentration of the glomerular capillary blood. This one, though, does not remain constant along the length of the capillary, but it progressively increases as fluid is filtered out of the capillary, right? And eventually it increases to a point where net ultrafiltration becomes zero and glomerular filtration stops. And this point is called the filtration equilibrium, right? And what I would have mentioned was actually explained or highlighted on the image, right? So changes in hydrostatic pressures in the glomerular capillaries are produced by changes in the resistance of the afferent and the efferent arteriole. Changes in the glomerular filtration rate occurs in opposite directions depending on which of the either the efferent or the afferent arteriole is affected. All right. So just to highlight a few things, right? When we have in the first one, image A, right? We have constriction of the afferent arteriole, right? So when you constrict the afferent arteriole, right, the hydrostatic pressure in the glomerular capillary is actually going to decrease, and renal plasma flow is going to decrease, and as a result, glomerular filtration rate is going to decrease, right? In B, when you constrict the efferent arteriole, it's actually kind of the opposite. So you have the increase in hydrostatic pressure in the glomerular capillary, right? And that is going to increase the glomerular filtration rate. All right. Just a little bit on the others. All right. When you have changes in the oncotic pressure in the glomerular capillaries, right? So when you have like an increased plasma concentration, right? You will have you won't really have any change in the renal plasma flow, but you will have a decrease in the glomerular filtration rate, right? And opposite, when you have a decrease in plasma protein concentration, you're going to have an increase in the glomerular filtration rate, right? And then lastly, we'll talk about constriction of the ureter. But we're going to talk about obstruction a little bit lower down, right? I will explain that one a little bit more. So measurement of the glomerular filtration rate, and ideally, this is done by measurement of a glomerular marker. Now, the glomerular marker, the gold standard, is a substance called inulin, right? And this is a fructose polymer with a molecular weight of about 5,000 delta, right? Now, inulin is used because it exhibits three characteristics of an ideal glomerular marker. Number one, a glomerular marker must be freely filtered across the glomerular capillaries with no change, with no size or charge restrictions. Number two, it cannot be reabsorbed or secreted by the renal tubule. And three, when it is infused, it cannot alter the GFR. All right. Inulin is not bound. So inulin is given IV. It is not bound to plasma proteins. It's not charged. And its molecular size is such that it can freely cross the glomerular capillary. And once filtered, it is completely inert, neither absorbed or secreted. And the amount of inulin that is filtered across the glomerular capillary is exactly equal to the amount of inulin that is excreted in the urine. All right. That is our gold standard. For what we use creatinine, right? creatinine is freely filtered across the glomerular capillaries. It is secreted to a very small extent, right, lower down on in the renal tubule, but it is not reabsorbed, and it's an endogenous substance. So therefore, it's a lot more practical to use creatinine, and that's something that we do regularly, right, to measure GFR, right? Blood urine nitrogen is also another marker of GFR that is used, and we know that we actually look at the ratios between the two to indicate if a patient has a pre-renal azotemia versus renal azotemia, right? So we spoke about filtration. Now let's talk about reabsorption, right? So water and other solids are reabsorbed from the filtrate into the capillary blood, and there are multiple reabsorptive mechanisms which exist in the proximal convoluted tubule, right, which involve multiple transporters. All right. If reabsorption didn't occur, then a lot of the constituents of the extracellular fluid would actually be lost in urine. And in the following slides, we will look at glucose and how glucose is actively reabsorbed, and urea, whereby urea is simply reabsorbed. So, this image, I just wanted to highlight the movement of the glucose in the proximal tubule. All right. So, glucose moves from the tubular fluid into the sodium glucose co-transporter, right, in the luminal membrane. And that is highlighted by our red circle, right? Two sodium ions and one glucose bind to the co-transport protein. The protein is then going to rotate in the membrane, and sodium and glucose are then going to be released into the intracellular fluid. In this step, glucose is actually being transported against an electrochemical gradient, but the energy for this actually comes from the movement of sodium. The sodium gradient is maintained by the sodium potassium ATPase, highlighted by our green circle, in the peritubular membrane. Because ATP is used to directly energize that transporter, right? This is secondary, this is active transport. Right? And glucose is also transported from the cell into the peritubular capillary blood by facilitated diffusion or blue circle, right? Glucose is moving down the electrochemical gradient and no energy is required for this step, right? The proteins involved in this is facilitated diffusion, is our GLUT1 protein and our GLUT2 proteins. And I said, as I would have mentioned before, this is an active process. Urea is a process. Right. So urea is transported in most areas of the nephron. The rate of reabsorption or secretion of urea is determined by the concentration difference for urea between tubular fluid and blood, and by the permeability of the epithelial cells to urea. That means that when there's a large concentration difference and the permeability is high, urea reabsorption is high. And when there's a small concentration difference and the permeability is low, reabsorption of urea is low. Urea, as I would have mentioned before, is freely filtered across the glomerular capillaries, and the concentration in the initial filtrate is identical to that in the blood. However, as water is reabsorbed along the nephron, the urea concentration in tubular fluid increases, and this creates a driving force for the passive urea reabsorption. In the proximal tubule, about 50% of the filtered urea is reabsorbed by simple diffusion, right? And as water is reabsorbed in the proximal tubule, the urea, its concentration is going to lag slightly behind, and the concentration of the urea in the lumen becomes slightly higher than the concentration in the blood, right? And this would then drive the passive urea reabsorption. So at the end of urea moving through the proximal convoluted tubule, 50% of the urea is absorbed and 50% remains in the lumen. In the thin descending limb, urea is secreted. There's a high concentration of urea in the interstitial fluid of the medulla. The thin descending limb of Henle's loop passes through the inner medulla, and urea diffuses from higher concentration in the interstitial fluid into the lumen of the nephron. More urea is then secreted into the thin descending limb than was reabsorbed in the proximal tubule, and thus at the bend of the loop of Henle, you now have 110% of the filtered load of urea is now present. In the thick ascending limb, the distal tubule and the cortical and outer medullary collecting ducts, these are impermeable to urea, so no urea transport actually occurs in these segments. However, in the presence of ADH, which we will talk about in detail further on, Water is reabsorbed in the late distal tubule and the cortical and outer medullary collecting ducts, and consequently, in these segments, urea is left behind, and the concentration of the tubular fluid becomes quite high. Right? And as I would have highlighted in the, well, not any picture, right? You have the presence, in the presence of EDH, right? Urea is going to be reabsorbed by our UT1, right? Our UT1, our urea transporter 1, moving down a concentration gradient from the lumen of the interstitial fluid into the inner medulla. That's urea. So secretion, a few substances are secreted from the peritubular capillary blood into the tubular fluid. So in addition to filtration, secretion actually provides a mechanism for excreting substances into the urine, right? Such as organic acids, organic bases, and potassium. And with reabsorption, secretion mechanism involve transporters in the membranes of the epithelial cells lining the nephron. And as lower down, we're going to get into those things. There's a few little things to mention, right? As it relates to um, renal, as it relates to autoregulation and renal flow. In acute kidney injury, where we have a sudden decline in renal function resulting in a reduced GFR and impaired fluid and electrolyte balance, right? You have in your pre-renal AKI patients who they have this results from reduced renal perfusion, and that is going to decrease our glomerular hydrostatic pressure and therefore decrease our glomerular filtration rates, leading to oliguria. Prolonged hyperperfusion progresses to intrinsic renal injury, right, or intrinsic AKI, whereby tubular epithelial injury, right, either from ischemia or nephrotoxins, impair filtration and tubular function, right? And in our post-renal acute kidney injury, obstruction to urine flow. So, like as I would have mentioned a few slides higher, in our patient who had like a ureteric obstruction, for instance, right? You have increase in the intratubular or the pressure in the Bowman's capsule, one of our opposing filtration pressures, which ultimately is going to reduce the overall net filtration and reduce our GFR. All right. Similar to in our patients who have some degree of trauma, renal trauma, any degree of trauma, right? Hemorrhage, loss of functional tissue results in a reduced amount of renal perfusion and a decreased GFR. Severe blood loss can produce a pre-renal AKI through hypovolemic shock, while direct renal parenchymal injury can cause intrinsic renal dysfunction. Right? Urotrauma, like such as trauma to the ureter, the bladder, urethra, disrupts the normal flow of urine, and that can cause extravasation of urine, obstruction, or retention. Right? Bladder injuries impair the normal coordination of the detrusor contraction and sphincter relaxation, and that can lead to failure of effective voiding and a potential post-renal AKI. Right? Unrecognized obstructions or urinary leakage can result in hydronephrosis, infection, and progressive renal impairment. In our septic patients, right, sepsis causes acute kidney injury through systemic inflammation, vasodilation, and impaired renal perfusion. Overall, that is going to decrease our renal blood flow and decrease our glomerular filtration rate. Septic shock causes hypotension and microcirculatory dysfunction, right, leading to renal ischemia and possible acute tubular injuries. Inflammatory mediators do cause some degree of endothelial dysfunction, leaky capillaries, and impaired tubular function, right? Sepsis from urological causes such as pyelonephritis, cat-associated infections, combines the negative effects of an infection with impairment in urinary drainage. Perioperative oliguria represents reduced urine output due to impaired renal perfusion, intrinsic nephron injury, or failure of urinary drainage, right? Pre-renal causes such as intraoperative blood loss, dehydration, hypotension, sepsis, or anesthetic-induced vasodilation is going to decrease our renal blood flow, which is going to decrease our glomerular capillary pressure, and ultimately is going to result in a decrease in the glomerular filtration rate. Intrinsic renal causes such as prolonged ischemia, sepsis-related inflammation, or nephrotoxic medications is going to cause tubular injury, impair filtration. Um, and then there are post-renal causes, which we kind of got went through before, right? Such as obstructed catheters, King's catheters, bladder obstruction from BPH, for instance, right? Neurogenic bladders, which we will talk about, right? Impairs bladder emptying, and that's going to increase the HIV cycle pressure, and that is going to cause a back pressure at the ureter and the kidney, and ultimately is going to cause a decrease in our glomerular filtration rate. So, regarding some of the major, well, not some of the major nephron segments, we started speaking on the proximal tubule, right? And this table just essentially was a nice summary that I saw in the Costanzo, right? Talking about the function of the segments, right? So we're going to talk about more of them in detail, right? So let's talk about sodium balance and how it relates to the other tubules. The renal mechanisms that are involved in the reabsorption of sodium are very important for the maintenance of normal extracellular fluid volume, normal blood volume, normal blood pressure, right? Sodium is freely filtered across the glomerular capillaries and is reabsorbed through the nephron. Excretion of sodium is actually less than 1% of the filtered load, but a net reabsorption of more than 99% of the filtered load overall. The bulk of sodium reabsorption occurs in the proximal convoluted tubule, where 2/3 of the filtered load is reabsorbed. In the proximal tubule, water reabsorption is always linked to sodium reabsorption, and the mechanism is described as isosmotic. The thick ascending limb of the loop of Henle reabsorbs about 25% of the filtered load of sodium. In contrast to the proximal tubule, where water reabsorption is linked to sodium reabsorption, the thick ascending limb is actually impermeable to water. The terminal portion of the renal tubule, such as the distal convoluted tubule and collecting ducts, reabsorb the rest of the last about 8%. The early distal convoluted tubule is going to absorb about 5%. And like the thick ascending limb is impermeable to water, the late distal convoluted tubule and collecting ducts reabsorb the last 3% of the filtered load and is responsible for essentially the fine-tuning of the sodium reabsorption and ensures the sodium balance. The late distal convoluted tubule and collecting ducts are the site of action of an important sodium regulating hormone, aldosterone. So specifically, in the proximal convoluted tubule, the early proximal convoluted tubule, sodium is reabsorbed primarily by carbonates and organic solids like glucose and amino acids. In the late proximal convoluted tubule, sodium is reabsorbed primarily with chloride, but without organic solids. But despite these differences between the early proximal and late proximal convoluted tubule, several statements can be made to describe the proximal tubule as a whole. The entire proximal tubule reabsorbs 67% of the filtered sodium. The entire proximal tubule also reabsorbs about 67% of the filtered water. The tight coupling between sodium and water reabsorption, as I would have mentioned before, is called the isosmotic reabsorption. And the bulk of reabsorption of sodium and water here is very important for maintaining our extracellular fluid volume. The proximal tubule is the site of glomerular tubular balance, which is also a mechanism for coupling reabsorption to the glomerular filtration rate. So specifically, in our early proximal convoluted tubule, this is where a very high amount of reabsorption work is done, indicating the luminal membrane contains many active transport mechanisms which derive their energy from the transmembrane sodium gradient. The co-transport mechanism in the luminal membrane of the early proximal tubule are sodium glucose, sodium amino acid, sodium phosphate, lactate or citrate, right? And in each case, sodium moves into the cell and down its electrochemical gradient, coupled to glucose, the amino acid, the phosphate, the lactate, or the citrate, which move into the cell against the electrochemical gradient. Sodium is then extruded from the cell into the blood by the sodium-potassium ATPase, our Greek ago, right? And glucose and the other solids are extruded by facilitated diffusion, which we touched on before. There is one counter-transport or exchange mechanism in the luminal membrane of the early proximal tubule, which is the sodium-hydrogen exchanger. Hydrogen is transported into the lumen in exchange for sodium, The hydrogen is then going to combine with filtered bicarbonate, converting it to carbon dioxide and water, which then move from the lumen into the cell. Inside the cell, carbon dioxide and water are reconverted to hydrogen and bicarbonates. The hydrogen is then transported again by the sodium hydrogen exchanger, and the bicarbonate is then reabsorbed into the blood by facilitated diffusion. And this cycle, and the net result of this cycle is the reabsorption of filtered bicarbonate. Thus, in the early proximal tubule, bicarbonate and not chloride is the anion that is reabsorbed with sodium. Also to note, there's a lumen negative potential difference across the cells of the early proximal tubule, which is created by the sodium glucose and the sodium amino acid co-transport. And these transporters bring net positive charges into the cell and leave negative charges in the lumen. Right? Other transporters are electroneutral, such as the sodium hydrogen exchanger, and therefore do not contribute to the trans-epithelial potential difference. All right. So as a result of all of these secondary active transport processes, there are several modifications of the glomerular filtrate by the time it crosses early proximal tubule. That is, 100% of the glucose and the amino acids are reabsorbed at this point in time. 85% of bicarbonate that was filtered is reabsorbed. Most of the filtered phosphate, lactate, and citrate have been reabsorbed. And because sodium reabsorption is coupled to each of these processes, it has also been extensively reabsorbed as well. So in the late proximal tubule, the fluid that enters has no glucose, no amino acids, and little bicarbonate. However, it has a very high concentration of chloride. The chloride concentration is high because, as we remember before in the previous slide, bicarbonate was preferentially reabsorbed, leaving chloride in the tubular fluid. And as the water was now reabsorbed along with solute, the tubular fluid chloride concentration is then going to increase and become higher than the chloride concentration of the glomerular filtrate and that of blood. In contrast to the early proximal tubule, the late proximal tubule reabsorbs primarily sodium chloride, and the high tubular fluid chloride concentration is now the driving force for reabsorption, for which there are multiple components. Right? So the specific cellular components, the luminal membrane of the late proximal tubule cells contains two exchange mechanisms, including the sodium hydrogen exchanger that we spoke about before, as well as a chloride formate anion exchanger, which is driven by the high tubular fluid chloride concentration. And the combined function of these two exchangers is to transport sodium chloride from the lumen into the cell. And sodium is then extruded into the blood via the sodium potassium ATPase, and chloride then moves into the blood by diffusion. So regardless, solid reabsorption is the primary event that happens in a proximal convoluted tubule, and water then follows passively. Right. So just to recap, sodium is going to enter the cell across the luminal membrane by any one of the mechanisms that we described previously. And because the luminal membrane of the proximal convoluted tubule was permeable to water, water is going to follow the solute to maintain an isoosmolarity. Sodium is then pumped out of the cell by the sodium potassium ATPase, which is located in the peritubular or the basolateral membrane, right? And as sodium is pumped out of the cell, water is then going to follow as well. There's a lateral intercellular space, which is an important route for reabsorption of solute and water. Isosmotic fluid accumulates in these spaces between the proximal tubule cells, right? And this isosmotic fluid in these spaces then acted upon by Starling's forces in the peritubular capillary. So now let's move on to the loop of Henle. So the loop of Henle comprises three segments. You have a thin descending limb, a thin ascending limb, and a thick ascending limb, right? And these segments are responsible for what is called the counter current multiplication, which is coming up so short. The thin descending limb is permeable to water and small solutes, And the thinner ascending limb is permeable to sodium chloride, but it's impermeable to water, right? In our countercurrent multiplication, we're going to see that water is moving out of the thin descending limb and solids move in, and the tubular fluid is going to progressively become hyperosmotic as it flows along the passageway of the loop of Henle, right? So let's look at the cells of the thick ascending limb before we delve into the um, our countercurrent multiplication. So in our thick ascending limb, the luminal membrane contains a sodium, potassium, 2-chloride co-transporter. It is a 3-ion co-transporter, right? And the energy for the co-transporter is derived mainly from the familiar sodium gradient, which is maintained by the sodium-potassium ATPase in the basolateral membrane. There's also a net reabsorption of sodium, potassium, and fluoride in the thick ascending limb. So all 3 ions are differently transported into the cell on the co-transporter. Sodium is extruded from the cell through the sodium potassium ATPase, and chloride and potassium diffuse through channels in the basolateral membranes down their respective electrochemical gradients. Right? And as shown in this figure, most but not all of the potassium that enters the cell on the 3-ion co-transport is going to leave the cell across the basolateral membrane. There's a small portion though that is going to diffuse back into the lumen. And one consequence of recycling the potassium across the luminal membrane is that the co-transport is actually electrogenic. It brings slightly more negative than positive charge into the cell, right? And the electrogenic property of the sodium potassium fluoride co-transporter causes a lumen positive potential difference across the cells of the ascending limb. The thick ascending limb, to note, is the site of action for our most potent diuretics, right, such as our furosemide. At physiologic pH, the loop diuretics are anions which attach to the chloride binding site of the sodium potassium chloride co-transporter. And when the diuretic is bounded to the chloride binding site, the 3-ion co-transporter is unable to cycle and then transport stops. At maximal dosages, loop diuretics completely inhibit sodium reabsorption in the thick ascending limb and can actually cause excretion of as much as 25% of the filtered sodium. The cells of the thick ascending limb are impermeable to water, right? And this is an unusual characteristic because almost all of the other cell membranes are permeable to water. And as a consequence of water impermeability, sodium chloride would be reabsorbed, but water is not reabsorbed with it. And for this reason, the thick ascending limb is also going to be called, can also be referred to as our diluting segment. We take the solutes, but water remains behind. And essentially, it leaves a dilute tubular fluid behind. So the corticopapillary osmotic gradient is a gradient of osmolarity in the interstitial fluid of the kidney that exists from the cortex to the tip of the papilla, right? The osmolarity of the cortex is approximately 300 milliosmoles, and that is similar to the osmolarity of other body fluids. But moving down, as we remember, as we are going down our layers into the depths of the kidney, into the papilla, the interstitial fluid osmolarity progressively increases. And at the tip of the papilla, the osmolarity can actually be as high as 1200 milliosmoles. Um, our corticopapillary osmotic gradient is formed by one, our countercurrent multiplication, which, as we would have mentioned, is a very specific function of our loop of Henle, right? And it is responsible for repulsing sodium chloride into the deeper regions of the kidney. And another process called urea recycling, which we're going to touch on a little bit, which is a function of the inner medullary collecting ducts, which essentially deposits urea. So the counter current multiplication process. So as I would have mentioned in the previous slide, its role is to deposit sodium chloride into the interstitial fluid of the deeper regions of the kidney. The counter current multiplication essentially builds up a gradient of osmolarity in the interstitial fluid through a repeating two-step process. The first step is called our single effect, and the second step is the flow of tubular fluid. So, in our initial step, in our initial step, the loop of Henle and the surrounding interstitial fluid have no corticopapillary osmotic gradient. And that is highlighted by the first diagram that is labeled initial state with the 300s in it, and there's only 300s in it. All right. So next we move to one. So we're focusing on one, number one, the single effect. Right. So sodium chloride is going to be reabsorbed out of the ascending limb and deposited in the surrounding interstitial fluid, and water is going to be left behind in the ascending limb, right? And as a result of that, the interstitial fluid osmolarity is going to increase, and that is highlighted in this picture by the 200s in the ascending limb and the 400s in the interstitial fluid. The fluid in the descending limb is then going to equilibrate with the fluid in the interstitial fluid. And that is how its osmolarity is then going to become 400. So that is how we have our 200, 400, and 400, number one. Step two is the flow of fluid. So now new fluid with an osmolarity of 300 is then going to enter the descending limb from the proximal tubule, and an equal volume of fluid is going to be displaced from the ascending limb. And as a result of this fluid shift, the high osmolarity fluid that was in the descending limb is now going to be pushed down towards the base, or pushed down towards the bend of the loop of Henle. Right. Based on the diagram, we could kind of see the gradient start to develop a little bit. All right. So this new fluid is going to get pushed down, and then you're going to have step three occurring again. Sodium chloride is then going to be reabsorbed out of the ascending limb and is going to be deposited in the interstitial fluid. And effectively, that is now how we are going. That is how we go from, in step two, in step two, how we go from 400, 400 to now 300, 500, because sodium chloride is now being reabsorbed out of the ascending limb. And the osmolarity of the interstitial fluid is then going to, the osmolarity of the interstitial fluid and the descending limb fluid is going to increase. And that is going to add to the gradient that was formed in the previous steps. Right? And the osmolarity of the fluid of the ascending limb is going to decrease further. And in step four, fluid is going to flow again. Now we have new fluid with an osmolarity of 300 milliosmoles entering the descending limb from the proximal tubule, which is going to displace fluid from the ascending limb. And as a result of the fluid shift, the high osmolarity fluid in the descending limb is pushed down towards the bend again. And essentially, it is the same thing that is happening in step two, right? But now we realize that the gradient of osmolarity is actually greater than what it was in step two. Now we're looking at 500 milliosmoles compared to 400 milliosmoles in step two, right? And essentially, these two steps, these two single effect flow fluid, single effect flow fluid are going to repeat and repeat until our gradient becomes established, right? And the size or the depth at which we can, or how strong we can form a gradient can be is dependent on the length of the loop of Henle. So just a note, as I would have mentioned a little bit prior, the osmolarity of the interstitial fluid and the bend in humans actually can go up to, can be about 1200, but in species, desert species such as desert rats, the osmolarity in a loop of Henle can go up to 3000, just for reference and comparison. So let's talk about antidiuretic hormone a little bit. So antidiuretic hormone has three actions in the renal tubule. It increases the water permeability of the principal cells of the late distal tubule and the collecting ducts, and it also increases the activity of the sodium-potassium chloride cotransporter of the thick ascending limb, and therefore it can actually enhance the countercurrent multiplication and the size of the corticopapillary osmotic gradient that we had previously discussed. Right? It can also increase the urea permeability in the inner medullary collecting ducts, but not in the cortical and outer medullary collecting ducts. And this actually enhances urea recycle, which is coming up in the next slide, and the size of the corticopapillary osmotic gradient. So of these actions, the effect of water permeability of the principal cells is best known, and physiologically is the most important. And in the absence of ADH, the principal cells are impermeable to water. In the presence of ADH, water channels or aquaporins are inserted in the luminal membrane of the principal cells, making them permeable to water. So just to go into the specifics of the mechanism, so when circulating level of ADH are high, ADH is delivered to the principal cells via the peritubular pulmonary blood. There are receptors for ADH which are present in the basolateral membrane, and these are coupled to adenylyl cyclase via stimulatory G protein. So we focus on that one. So when ADH binds the receptors, adenylyl cyclase is activated and catalyzes the conversion of ATP to cyclic AMP. All right. Cyclic AMP then activates protein kinase A, which an activated protein kinase A then causes phosphorylation of intracellular structures. Right. And after this phosphorylation step occurs, vesicles containing water channels are then shuttled to and inserted into the luminal membrane of the principal cell, thus increasing its water permeability. And this specific water channel that is controlled by ADH is called aquaporin. Back to our our gradient. We need to talk about the the process of urea recycling. So urea recycling from the inner medullary collecting ducts is the second process that contributes to our corticopapillary osmotic gradient. All right. And the circle numbers, as you will see here, I will talk about the steps. Right. At one, the cortical and outer medullary collecting ducts, ADH is going to increase water permeability, but does not increase urea permeability. And as a result, water is reabsorbed from the cortical and outer medullary collecting ducts, but urea remains behind in the tubular fluid. Right. This differential effect of ADH on water and urea permeability in cortical and outer medullary collecting ducts cause the urea concentration of the tubular fluid to increase. In the inner medulla or the inner medullary collecting ducts, ADH increases water permeability and increases the transporter for facilitated diffusion of urea, or urea transporter 1 or UT1. Right? And this is a contrasted effect on only water permeability in cortical and outer medullary collecting ducts. And because the urea concentration of tubular fluid has now been elevated by the reabsorption of water in cortical and outer medullary ducts, a larger concentration gradient has now been created for urea. So in the presence of ADH, the inner medullary collecting ducts can transport urea, and urea diffuses down its concentration gradient into the interstitial fluid, and therefore urea that would have otherwise been excreted is now recycled into the inner medulla, where it adds to the gradient. So as implied by this mechanism, it depends heavily on ADH. So when ADH levels are high, as in water deprivation, differential permeability effects occur and urea is recycled into the inner medulla, right? When levels are low, as in drinking water or in conditions such as central diabetes insipidus, the differential permeability effects do not occur and urea is not recycled. So how is urine concentrated, or how do we produce hyperosmotic urine? So by definition, this is urine which has an osmolarity that is higher than blood osmolarity. Hyperosmotic urine is produced when circulating levels of ADH are high and occurs in water deprivation or in conditions as syndrome of inappropriate antidiuretic hormone. The osmolarity of glomerular filtrate is identical to that of blood when it starts off. It's about 300 milliosmoles because water and small solids are freely filtered. The osmolarity remains at 300 milliosmoles along the entire length of the proximal convoluted tubule as highlighted there, even though a significant amount of water is reabsorbed. And this is because water is always reabsorbed in exact proportions to solids, an isoosmotic process. When along the thick ascending limb of the loop of Henle, sodium chloride is reabsorbed by our sodium potassium chloride co-transporter. And because the cells of the thick ascending limb are impermeable to water, water reabsorption cannot accompany solutes. So as solute is reabsorbed, water is left behind and the fluid is diluted. That's how we go from 300 to 100 in this picture. And the osmolarity of the tubular fluid in this segment is 100. And the thick ascending limb is also called diluted segment, which you mentioned before. In the early descending tubule, Sodium chloride is reabsorbed by a sodium chloride co-transporter, and like in the thick ascending limb, cells of the early distal tubule are impermeable to water, and water reabsorption cannot follow solute reabsorption. And here, the osmolarity of the tubular fluid becomes even more dilute, as low as 80 milliosmoles, and the early distal tubule is also called the cortical diluting segment. In the late distal tubule, the principal cells are permeable to water in the presence of ADH. And recall that we now have a very dilute fluid coming in, but now they are permeable to water. So water now flows out of the tubular fluid by osmosis, driven by the gradient across the cells, and water reabsorption will then continue until the tubular fluid equilibrates osmotically with the surrounding interstitial fluid. And the tubular fluid now leaving the distal tubule after being equilibrated now has an osmolarity of 300. Now, going from 300 to the collecting ducts, the mechanism is the same as essentially for what happened in the distal tubule. The principal cells of the collecting ducts are permeable to water in the presence of ADH, and as tubular fluid flows down the collecting duct, it is exposed to the interstitial fluid with now an increasing higher osmolarity, which was formed earlier by our corticopapillary osmotic gradient. Water is then reabsorbed and reabsorbed until the tubular fluid equilibrates osmotically with surrounding interstitial fluid. And finally, that is how we get concentrated urine. Additive, which is about 1200 on average, 1200 milliosmoles. So, as we would have mentioned also previously, the appropriate response to water deprivation is production of hyperosmotic urine. However, in syndrome of inappropriate antidiuretic hormone or SIADH, hyperosmotic urine is produced inappropriately. Right? We have high levels of circulating hormones, circulating ADH, owing to either excessive secretion from the posterior pituitary, from like a head injury, or secretion of ADH from abnormal sites such as lung tumors. And in these conditions, we know that ADH is being produced without any osmotic stimulus, right? It is just being produced, right? In SIADH, high levels of ADH increase water reabsorption by the late distal tubular collecting ducts, making the urine hyperosmotic and diluting plasma osmolarity. So we know that normally low plasma osmolarity would inhibit secretion of ADH, but in SIADH, this feedback inhibition does not occur because of the autonomous secretion of the ADH, right? So on the flip side, how do we produce hypoosmotic or dilute urine? So by definition, dilute or hypoosmotic urine is urine that has a lower osmolarity than blood osmolarity. Hyperosmotic urine is produced when there are low circulating levels of ADH, for example, in patients who are drinking a lot of water or patients who have diabetes insipidus, right? Central or nephrogenic. Central, central and nephrogenic. And the mechanisms for the production of hypoosmotic urine, let's talk about. All right. So in this diagram, right, we have there's a heavy outline portion that indicates the segment of the nephron which is impermeable to water, right? And it now includes the thick ascending limb and the entire distal tubule and collecting duct, right? There is still a corticopapillary osmotic gradient, but know that it is significantly smaller than the presence of the ADH, right? The smaller gradient is understood from the positive effects of ADH, right? And that it has on the countercurrent multiplication and on urea recycling, and in the absence of ADH, these processes are diminished, and the size of the gradient is also diminished. So, starting from the top, reabsorption in proximal tubule is not affected by ADH. We know that. So the absence of ADH fluid is then reabsorbed isosmotically, right? We have about 300 milliosmoles. In the thick ascending limb of the loop of Henle, sodium chloride is going to be reabsorbed by the sodium potassium chloride co-transporter. Water is not reabsorbed. Water is not reabsorbed because of the impermeability of the segment, and the tubular fluid is diluted. That's how we go from 300 to 120. Right? Note that is not as quite low as in the presence of ADH as in before, because dilution step is diminished in the absence of ADH. Right? In the early distal tubule, dilution is going to then continue. Right? Sodium chloride is going to be reabsorbed by the transporter, but the cells are impermeable to water. Right? The fluid is that is then leaving the distal tubule has an osmolarity of 110. Right? In the late distal tubule and collecting ducts, that is what exhibits the most dramatic and important difference in if when ADH is low and absent. This segment is now wholly impermeable to water and no fluid is flowing through them, and no osmotic equilibration is possible. Although tubular fluid is exposed to the increasingly higher osmolarity of the gradient, water is not reabsorbed in response to the osmotic driving force, and therefore the final urine that is produced is not equilibrated with the osmolarity at the tip of the papilla, and that is how we are going to end up with a 75 at the bottom. Right. So let's talk about diabetes insipidus for a little bit, such as this nephrogenic. Central diabetes insipidus can follow a head injury in which trauma depletes the stores of ADH on the posterior pituitary, right? Therefore, it is unable to secrete ADH response to a stimulus. And because circulating levels of ADH are low or zero, the entire distal tubule and collecting ducts are now impermeable to water. And that's how we can end up, or the patient end up secreting large volumes, even up to 50 liters a day of dilute urine. Plasma osmolarity is going to increase to abnormally high values because of this excess amount of water that's going to be excreted in the urine. A high plasma osmolarity normally stimulates ADH secretion, but when you're in central diabetes insipidus, no ADH is being secreted. And we treat by administrating a ADH annual. For our nephrogenic diabetes insipidus, there's a defect in the response of the kidneys to our antidiuretic hormone. Even though antidiuretic hormone is secreted normally, a defect in the receptor, the GS protein or the adenylyl cyclase, which makes the principal cells unresponsive to ADH. And as a result, ADH cannot increase water permeability in the late distal tubule and collecting ducts. And as in central diabetes insipidus, water cannot be reabsorbed by these segments, and large volumes of dilute urine are going to be excreted. The plasma osmolarity increases, and that stimulates the posterior pituitary to secrete even more ADH. So let's move on to the cells of the distal tubule, right? The early distal tubule reabsorbs about 5% of the filtered sodium. At the cellular level, the mechanism is a sodium chloride co-transporter in the luminal membrane, the energy from which comes from the sodium gradient. There's a net reabsorption of sodium and chloride in the early distal tubule, right? Both ions are going to enter on the sodium chloride co-transporter. Sodium is then extruded from the cell into the blood by the sodium potassium ATPase, and chloride diffuses out of the cell through the chloride channels in the basolateral membrane. The sodium chloride co-transport of the early distal tubule differs from that again of the thick ascending limb. It transports 2 ions, not 3, and is inhibited by a totally different class of diuretics, which is the thiazide diuretics. And like with loop diuretics, thiazides are organic acids, and these are anions at physiological pH. Thiazides bind to the chloride site of the transporter and prevent it from cycling, inhibiting sodium chloride reabsorption in the early distal tubule. And like in the thick ascending limb, the early distal tubule is impermeable to water. Thus, it is reabsorbing solutes, leaving water behind, right? Giving us our dilute urine. In the late distal tubule and the collecting duct, there are two major cell types which are interspersed along the segments. There are the principal cells, and they are the alpha intercalated cells. The principal cells are involved in the sodium reabsorption, potassium secretion, water reabsorption, and the alpha intercalated cells are involved in potassium reabsorption and hydrogen secretion. Right? Let's focus specifically on the principal cells. Right? As we have mentioned before, the late distal tubule and the collecting duct only reabsorb a small amount, about 3% of overall filtered sodium. Quantitatively, this amount is small when compared with the amounts reabsorbed in the proximal tubule, the thick ascending limb, and even the distal tubule. The late distal tubule and collecting duct, however, the last segments of the nephron to influence the amount of sodium to be excreted. It makes the fine adjustments. The mechanism for the sodium reabsorption in the principal cells is highlighted in this picture rather than couple transport mechanisms in the previous nephron segment. The membrane contains sodium channels, right? Called ENaC or epithelial sodium channels, and sodium diffuses through the channels down an electrochemical gradient from the lumen of the tubule and into the cell. Right? Sodium is then extruded from the cell via sodium potassium ATPase in the basolateral membrane. And the anion that is going to accompany sodium is mainly chloride. But this mechanism for chloride has not exactly been established, at least in this part of the tubule. So a useful concept to understand the regulation of sodium balance is something called effective arterial blood flow. And that is the portion of the extracellular fluid volume contained in the arteries and is the volume effectively fusing tissues. In general, changes in the extracellular fluid volume lead to changes in the effective arterial blood volume in the same direction. For example, increases in extracellular fluid volume, like extracellular fluid volume, are associated with increases in EABV, and decreases in the extracellular fluid volume are associated with decrease in the EABV. Right? There are a few exceptions, such as in patients with edema. There's an increase in ECF associated with a decrease in the EABV due to excessive filtration of fluid out of the capillaries and into the interstitial fluid. Right? So we had kind of touched on this a little bit before initially. Right? So we're going to touch on it again. The kidneys are going to detect changes in the EABV and through a multiple mechanism, direct changes in sodium excretion that attempt to restore the EABV towards normal. Mechanisms that regulate the sodium excretion include sympathetic nerve activity, right? Atriopeptin, the Starling's forces in the peritubular capillaries, and the renin angiotensin aldosterone system. With regard to the sympathetic activity, this is activated by a baroreceptor mechanism in response to a decrease in the arterial pressure and causes vasoconstriction of the afferent arterioles and increased proximal tubule sodium reabsorption. Atriopeptin, or ANP, is secreted by the atria in response to an increase in the extracellular fluid volume, right? And that is going to cause vasodilation of the efferent arteriole, increasing the GFR and decreasing the sodium reabsorption in the late distal tubule and collecting ducts. Right? Starling's force in the peritubular capillaries. Right? We kind of spoke on this before, but briefly, increasing the extracellular fluid volume dilutes the capillary oncotic pressure and inhibit the proximal tubule sodium reabsorption, and it decreasing the extracellular fluid volume concentrate the the oncotic pressure in the capillary and stimulate proximal tubule sodium reabsorption. And regarding the renin angiotensin aldosterone system, this is activated in response to decreased arterial pressure, right? Angiotensin 2 is going to stimulate the sodium reabsorption in proximal tubule, and aldosterone stimulates sodium reabsorption in distal collecting tubule, right? So specifically as it relates to this diagram and the next diagram, this diagram is showing a response to when a person has an increase in their sodium intake. When a person eats a diet high in sodium, because sodium is primarily going to be distributed in the extracellular fluid, there's an increase in extracellular fluid volume and the EABV. That increase is then detected, and the kidneys then orchestrate the mechanisms to increase sodium excretion that is now going to attempt to return the extracellular fluid volume and the EABV to normal. Conversely, the opposite happens when a decreased amount of sodium intake occurs. When a person eats a diet low in sodium, there's a decrease in the extracellular fluid volume and a decrease in the EABV. That is detected, and the kidneys then orchestrate their way of decreasing sodium excretion to attempt to return the ECF volume back to normal. So that was sodium and chloride. Let's talk about potassium. So potassium is 98% of total body potassium is intracellular. Therefore, the intracellular concentration of potassium is going to be significantly greater than the extracellular concentration of potassium. And this is maintained by the sodium potassium ATPase that is present in all cell membranes, right? And distribution of potassium across cell membrane is called the internal potassium balance. And mechanisms which allow the variation of urinary excretion of potassium is called the external potassium balance. So, with regards to the internal potassium balance, like I said in the last slide, most of the potassium is present inside the cells, and therefore even small shifts of potassium across cell membranes can cause large changes in potassium concentration in the extracellular fluid and the blood. Potassium shifting out of cells refers as hyperkalemia. Potassium shifting into cells refers as hypokalemia. Right? And there are multiple causes that we're just going to touch on briefly. Right? Insulin stimulates the potassium uptake into the cells by increasing the activity of the sodium potassium ATPase. And physiologically, this effect is responsible for the uptake of the dietary potassium into the cells following a meal. Thus, in response to food ingestion, right, insulin, after being secreted by the endocrine pancreas, right, will stimulate the uptake of potassium into cells, right. This action ensures that any ingested potassium does not remain in the extracellular fluid and produce hyperkalemia and all of its effects. Deficiency of insulin, as occurs in like patients with type 1 diabetes, produces the opposite effect: decreased uptake of potassium into cells and hyperkalemia. Right. Also, just to touch on it, some acid-base abnormalities are often associated with potassium disturbances, right? And one of the mechanisms do involve the underlying internal potassium balance involving the hydrogen potassium exchange across cell membranes, right? And this exchange is useful because the intracellular fluid actually has a considerable buffering capacity for H plus ions. In order to take advantage of these buffers, H plus must either enter or leave the cells. And to preserve electron neutrality, H plus cannot enter or leave by itself. It must be either accompanied by an anion or it must be exchanged for another cation, potassium. In alkalemia, H plus concentration in blood is decreased. H plus leaves the cells and potassium enters, producing a hypokalemia. And on the other hand, in acidemia, the hydrogen concentration in blood is increased. H plus enters and potassium leaves, causing a hypokalemia. But that is not to say that all acid-base disturbances are going to produce a change in potassium. There's also the effect of adrenergic agonists and antagonists, right? So catecholamines do alter the distribution of potassium across cell membranes by two separate receptors and mechanisms. Activation of the beta-2 adrenergic receptors by beta-2 agonists, for example, albuterol, increases the activity of the sodium-potassium ATPase and causes a shift of potassium into cells and may produce a hypokalemia. On the other hand, activation of alpha adrenergic receptors causes a shift of potassium out of cells and may produce a hyperkalemia. And the effect of adrenergic antagonists on the blood potassium concentration can also be quite predictable. Beta-2 adrenergic antagonists like propranolol and cause a shift of potassium out, and alpha adrenergic antagonists cause a shift of potassium in. Right. Also, let's look at osmolarity. Hyperosmolarity or increased osmolarity of the extracellular fluid causes a shift of potassium out of cells, and this mechanism involves the flow of water across the membranes, which occurs in response to a change in the extracellular fluid osmolarity. If the osmolarity of the extracellular fluid is increased, water flows from intracellular fluid to extracellular fluid because of the gradient, and as water leaves the cells, the intracellular potassium concentration is going to increase, which then drives the diffusion of potassium from the intracellular fluid to the extracellular fluid. Essentially, the flow of water is causing potassium to drag with it. Cell lysis, or the breakdown of cell membranes, releases a large amount of potassium from the intracellular fluid and can produce hypokalemia. Exercise also causes a shift of potassium out of cells, Depletion of cellular ATP stores opens potassium channels in the muscle cell membranes, and potassium moves out of the cells down its gradient. And usually, the shift is small and produces only a slight increase in blood potassium concentration, which is reversed during a subsequent period of rest. But in a person who is treated with beta adrenergic antagonists, which independently produces a shift out of the cells, or in those with impaired renal function, which is unable to be adequately excreted, strenuous exercise can result in hyperkalemia. Um, Normally, urinary excretion of potassium is equal to the dietary potassium, and that is minus small amounts of potassium that is lost from the body via extrarenal routes, such as the GIT. Essentially, long to make it simpler, potassium excreted should be equal to the potassium. There's a potassium balance which exists when the potassium that is excreted is equal to the potassium that is taken in, right? And if you go into a positive potassium balance where you intake more than you can excrete, you can go into hyperkalemia, and you can get a negative balance where you excrete more than you intake, you can go into hypokalemia. So potassium is not bound to plasma protein and it is freely filtered. The proximal convoluted tubule is going to reabsorb about 67% of filtered potassium, and the thick ascending limb reabsorbs an additional 20%. The distal tubule and collecting ducts are responsible for fine adjustments in potassium. Um, when uh when you are low in potassium, potassium can be reabsorbed by the terminal nephron. So the luminal membrane of the cells, as you were spoken about before, contains a hydrogen potassium ATPase similar to that in other body tissues like the gastric cells. And that hydrogen potassium ATPase is the primary active transport mechanism that pumps hydrogen from the cell to the lumen and simultaneously pumps potassium from the lumen into the cell. Potassium then diffuses from the cell into the blood. Potassium then diffuses from the cell into blood via potassium channels. Potassium can be secreted by principal cells, right? And the function of the principal cells is to secrete rather than to absorb. Thus, the cellular mechanism in the principal cells is going to differ from that in the alpha intercalated cells. Potassium secretion is net transfer of potassium from blood into the lumen. Potassium is brought into the cell from the blood via the sodium potassium ATPase, which is responsible for maintaining the high intracellular potassium concentration. And both the luminal and basolateral membranes have potassium channels. So theoretically, potassium can diffuse into the lumen or back into the blood. The potassium permeability and the size of the electrochemical gradient for potassium are higher in the luminal membrane. Therefore, most of the potassium diffuses across the membrane rather than being recycled across the basolateral membrane into the blood. That's potassium. Let's talk about water balance. Now, body fluid osmolarity is maintained at a value of about 290 milliosmoles in water by osmoregulations, right? And small deviation in body fluid osmolarity produce a set of hormonal responses that alter water reabsorption by the kidneys, attempting to return osmolarity back to normal, right? Um, there are various renal mechanisms which are responsible for maintaining constant body fluid osmolarity, and control of water balance is exerted at the level of the late distal tubule and the collecting duct. When urine osmolarity is equal to blood osmolarity, it's called isosmotic urine. When urine osmolarity is higher than blood osmolarity, it is called hyperosmotic urine. And when urine osmolarity is lower than blood osmolarity, it's called hyperosmotic. All right. So this is going to essentially recap on what we would have spoken about on when we mentioned ADH and we introduced ADH on before, right? In water, in the first one, right? Water is continuously lost from the body from sweat, water vapor, insensible losses. And if it's not replaced by drinking water, then the osmolarity is going to increase. The increase in osmolarity stimulates osmoreceptors in the anterior hypothalamus, which are exquisitely sensitive and are stimulated by increases in osmolarity of less than 1 milliosmole. Stimulation of the osmoreceptors has two effects. It stimulates thirst, which drives drinking behavior. It also stimulates secretion of EDH from the posterior pituitary gland, right? And as we would have mentioned before, EDH is going to be released, is going to be circulated, and is going to increase the permeability of the principal cells of the late distal tubule collecting duct. The increased permeability of water causes increased water reabsorption, and more water is going to be reabsorbed by these segments, right? Urine osmolarity is going to increase, urine volume is going to decrease, and increased water reabsorption means that more water is going to be returned to the body fluids. So couple that, the action of EDH plus increased thirst, drinking behavior, plasma osmolarity is going to decrease and it's going to go back toward the normal value. And this is an example of negative feedback, right? Likewise, the flip, when you drink water, right, the ingested water is going to be distributed. And because the amount of solute in the body is going to be unchanged, the added water will dilute body fluid and cause a decrease in plasma osmolarity. The decrease in the plasma osmolarity is going to inhibit the osmoreceptors in the anterior hypothalamus. Inhibition of the osmoreceptors has two effects. It is going to decrease this and suppress water drinking behavior. It is also going to inhibit secretion of EDH from the posterior pituitary gland. Inhibition of EDH means you have less circulating levels of EDH, less EDH going to the kidneys. Lower EDH is going to decrease the permeability of the cells of the distal tubule and the collecting duct, and that is going to result in decreased water reabsorption, which is going to be excreted, decreasing urine osmolarity, increasing urine volume, right? And now that we have less water reabsorbed, less water is returned to circulation, and this coupled with inhibition of thirst and the suppression of drinking water, plasma osmolarity is going to increase back towards normal fat. So moving on to the renin angiotensin aldosterone system. This is a hormonal system that is essential for the regulation of blood pressure and fluid balance. And the system is mainly comprised of the three important hormones, really. We have renin, angiotensin 2, and aldosterone. And it's primarily activated in response to reduced renal perfusion. And it functions to restore circulating volume and arterial pressure. So renin is released specifically from the granular cells of the renal juxtaglomerular apparatus in response to one of three factors. Reduced perfusion pressure of the kidney, which is detected by baroreceptors in the afferent arteriole. Reduced sodium delivery to the distal convoluted tubule, which is detected by the macular denser cells, or sympathetic stimulation of the juxtaglomerular apparatus via beta-1 adrenoceptors. The release of renin is inhibited by atrionatriuretic peptide. When blood pressure increases, the cardiac atria stretches during filling, leading to ANP release. Circulating levels of renin is going to cleave angiotensinogen, which is a precursor protein produced in the liver to form angiotensin 1. Angiotensin 1 is then going to be converted to angiotensin 2 by the angiotensin converting enzyme, which is produced in the lungs. All right. Mainly found on the surface of the vascular endothelial cells, but can also be secreted from renal endothelium in small amounts. Angiotensin 2 exerts its effect by binding to various receptors throughout the body. It binds to one of two G protein coupled receptors, AT1 and AT2, with most of the action mediated at the AT1 receptor. Angiotensin 2, as highlighted by the green rectangle on the image, does have a few systemic effects which helps to increase blood pressure. So number one, angiotensin 2 has cardiovascular effects. It is a potent vasoconstrictor. It acts on AT1 receptors in the arteriolar endothelium to activate the GQ protein, which causes a signaling cascade to increase intracellular calcium, causing vasoconstriction. And this is going to act to increase total peripheral resistance and consequently increase blood pressure. It also acts at the hypothalamus to increase thirst, increasing fluid consumption. It increases ADH secretion in the posterior pituitary, which increases renal reabsorption of water, which we went through before. And together, this can increase circulating volume and blood pressure. It also is going to act on the adrenal cortex to release aldosterone. It also stimulates the sympathetic nervous system to increase noradrenaline release. It has over and noradrenaline in to increase cardiac output, cause vasoconstriction of the arterioles, and also helps to further increase renin release. At the kidney level, angiotensin 2 helps to preserve glomerular filtration and increase sodium reabsorption by a few mechanisms. One, it causes vasoconstriction of the renal artery and the afferent arteriole. It causes vasoconstriction of the efferent arteriole to a larger degree than the afferent arteriole. It also causes contraction of the mesangial cell, leading to a decreased filtration area and reduced GFR. These occur via AT1 receptor, right, which causes opening of voltage-gated calcium channels, which cause the influx of calcium, increasing sodium reabsorption at the proximal convoluted tubule. This occurs by increasing the activity of the sodium hydrogen antiportal activity. Also cause adjustment in startle forces in the peritubular capillary, increasing reabsorption. Increased water reabsorption in the collecting ducts indirectly occurs via EDH and the aquaporin 2 receptors. So that is angiotensin. Aldosterone by the green rectangle. This is a mineralocorticoid and steroid hormone which acts on the principal cells of the collecting ducts. In F1, it increases the expression of epithelial sodium channels, promoting urinary sodium reabsorption. So the additional sodium that is reabsorbed through these channels is then pumped back into the blood via the sodium-potassium pump, and the potassium from the blood enters the principal cell of the nephron in exchange for sodium, and this potassium exits the cell into the renal tubule to be excreted in the urine, reducing levels of potassium in the blood. Ultimately, aldosterone increases sodium reabsorption, allowing for greater fluid retainment and therefore increased intravascular volume and blood pressure, whilst potassium is lost in the urine by the action of aldosterone. So quickly, coming down towards the end, let's just discuss the body fluid compartment that we would have mentioned before, ECF, ICF. Water is 50 to 70% of body weight, on average about 60%, and the percentage varies based on gender and the amount of adipose tissue. Water is inversely proportional to fat content. Men tend to have higher water content, lower fat content, and women it's opposite. Total body water is distributed between two compartments. You have the intracellular fluid compartment and the extracellular fluid compartment. Intracellular fluid compartment is 2/3 of the total body water, and the extracellular fluid compartment is 1/3. In terms of body weight, 40% of body weight is going to go to the intracellular fluid, and 20% is going to go to extracellular fluid. Extracellular fluid is going to be further subdivided into interstitial fluid, which is 3/4 of it, and plasma, which is 1/4. Just on an aside note, there's also a transcellular compartment, and that transcellular compartment is where contains or things that fall under the transcellular compartment would be like your CSF, the pleural fluids, digestive fluids. Quantitatively, it's actually a very small compartment. In the interstitial fluid, that is composed of intracellular fluid, right? Water inside the cells in which all the solids are dissolved, and I would have mentioned before, that is to the total body weight of total body water, 40% of body weight. And the major cations here would be your potassium, your magnesium. Major anions would be your proteins, organophosphates, like your ATP, ADP, AMP. In the extracellular fluid, that is the water outside of the cells, 1/3 of the total body weight. Total body water, 20% of body weight. Extracellular fluid is made up of plasma, and the interstitial fluid is the cells, and the major cations in this compartment is sodium, and the major anions are chlorine and bicarbonate. Then we have, further in our breakdown, we have plasma, which is the aqueous component of blood, and that suspends all blood cells. 25% of the blood volume is made up of red blood cells, white blood cells, and platelets. Oh, sorry. Plasma is 55% of the blood volume. And your cells, your red blood cells, your white blood cells, your platelets are the remaining 45%. Interstitial fluid is an ultrafiltrator of plasma and it has the same composition of plasma, including plasma protein and blood cell. And it is formed by filtration across capillary walls. Next, let's touch on the physiology of micturition. This is the process by which the urinary bladder empties when it becomes filled, and it involves two main steps. Um, there is a the bladder is going to fill progressively until the tension in the wall rises above the threshold level. That is our storage phase, and there are micturition reflex, a nervous reflex that empty the bladder or at least cause the conscious desire to urinate or avoid it phase. Before we go into the two phases, let's just talk quickly on the innervation of the bladder. I'm almost done. The principal nerve supply of the bladder is by the pelvic nerves, which connect the spinal cord through the sacral plexus, mainly connecting the cord segments S2 and S3. Coursing through the pelvic nerve are both sensory nerve fibers and motor nerve fibers. The sensory fibers detect the degree of stretch in the bladder wall. Stretch signals from the posterior urethra are strong and are mainly responsible for initiating reflexes that cause bladder emptying. Motor nerves transmitted in the pelvic nerves are parasympathetic fibers, and these fibers are going to terminate on ganglion cells located in the wall of the bladder. And then there are short postganglionic nerves that are then going to innervate the detrusor muscle itself. In addition to the pelvic nerves, right, there are two other types of innervation that are important. There's skeletal motor fibers transmitted via the pudendal nerve to the external bladder sphincter, and these fibers are somatic fibers that innervate and control voluntary skeletal muscle, as well as a sympathetic innervation from the sympathetic chain through the hypogastric nerve, connecting mainly with the L2 segment of the spinal cord. So, storage phase. So, as the bladder fills, applying stress to the rugae of the bladder, the muscular walls are going to relax and distend. And this is going to increase the functional capacity of the bladder. This allows pressure within the bladder or the intravesical pressure to remain relatively constant over a very large volume. And this receptive relaxation is also known as the stress relaxation phenomenon and is responsible and is vital to the storage of urine and help prevent leakage during the storage phase of micturition by ensuring the intravesical pressure remains lower than urethral pressure. Regarding the neural control of the storage phase, the pontine continent center, or the PCC, controls the storage phase of micturition at the highest level and coordinates the continent centers in the spinal cord. To store urine, the detrusor muscle of the bladder must relax, while both the internal urethral sphincter and external urethral sphincter contract. The bladder and the internal urethral sphincter is under autonomic control, and the external urethral sphincter is under somatic control. As the bladder fills, stretch receptors in the detrusor muscle are going to generate low-frequency afferent signals that travel via the pelvic nerve to the sacral spinal cord and the higher centers, and these signals indicate bladder fullness. But however, they are actively suppressed by higher brain centers to prevent activation of the micturition reflex. The cerebral cortex sends impulses to the PCC, which coordinates the detrusor relaxation and sphincter contraction. Descending signals from the PCC activate sympathetic nuclei in the thoracolumbar spinal cord, and these sympathetic nuclei use the hypogastric nerve to release noradrenaline at the bladder, causing the detrusor muscle relaxation via stimulation of beta-3 adrenoceptors in the fundus and body of the bladder, and the internal urethral sphincter contraction via stimulation of alpha-1 adrenoceptors at the bladder neck. Note simultaneously, parasympathetic outflow via the pelvic nerve is inhibited, and that prevents the detrusor contraction during bladder filling. Continuous inhibition of the periaqueductal gray ensures that afferent input does not activate the pontine micturition center. Voluntary somatic control of the external urethral sphincter is achieved via the pudendal nerve, which activates nicotinic cholinergic receptors in the striated muscle of the external urethral sphincter, causing it to contract. And this prevents any urinary leakage to the external sphincter. That's our storage phase. So, voiding phase, right? The passing of urine is under unconscious parasympathetic control via a spinal reflex which undergoes remodeling during childhood, allowing it to be overridden at various control points by higher voluntary somatic control. So for micturition to occur, the detrusor muscle must contract while the internal with the going presence milk and the external uterus sphincter relax concomitantly. Regarding the primitive reflex, as the bladder reaches capacity, stretch receptors in the detrusor muscle are intensely activated and bladder efferents send signals via the pelvic nerve to the spinal cord. Efferent signals are then sent back to the detrusor via the parasympathetic fibers in the pelvic nerve, releasing acetylcholine at the neuromuscular interface. Acetylcholine then acts on the muscarinic acetylcholine receptors, or the M3 receptors on the detrusor muscle, causing contraction and increased intravesicular vesicular pressure. And this is essentially the micturition reflex. However, after 2 years of age, following extensive remodeling, voluntary control of this reflex arc is gained by higher centers. So instead of synapsing in the spinal cord, information from bladder afferent are sent via the spinal cord to the periaqueductal brain, midbrain, to the pontine micturition center and the cerebral cortex. So although the pontine micturition center now stimulates the efferent limb of this reflex, the primitive spinal reflex is still relevant in pathological states. Higher brain centers can voluntarily inhibit or facilitate the micturition reflex, primarily via the pontine micturition center. The PMC and micturition reflex is normally inhibited by higher centers until the decision to urinate is made. Upon a voluntary decision to urinate, inhibition of the PMC is released, and this allows the PMC to stimulate the sacral preganglionic parasympathetic neurons, causing detrusor contraction. The PMC also suppresses Onuf's nucleus in the sacral spinal cord, reducing the somatic activity of the pudendal nerve and voluntary contraction of the external urethral sphincter. And this causes the relaxation of this external sphincter. Simultaneously, in response to bladder afferents from a full bladder, the PMC also reduces sympathetic stimulation of the hypogastric nerve, allowing relaxation of the internal urethral sphincter, and this allows the urethra to distend, enabling the passage of urine. Once micturition has begun, bladder contractions lead to increased stimulation of afferents and increased contraction in a positive feedback and self-regenerating process, and this ensures the bladder empties. In the female, urination is assisted by gravity, while in the male, the bulbous spongious muscle contractions along the length of the penis also helps to expel all of the urine. So let's talk a little bit about neurogenic bladder. We're wrapping up now. Neurogenic bladder is a disorder of the lower urinary tract function resulting from disease or injury of the central or peripheral nervous system that disrupts the normal neural control of bladder storage and void. It is characterized by abnormalities of the detrusor and or urethral sphincter function, leading to impaired urine storage, impaired bladder emptying, or both. Depending on the level and the severity of the neurological lesion, neurogenic bladder may manifest as detrusor overactivity or hyperreflexia, detrusor sphincter dyssynergia, or detrusor underactivity or acontractility, and may be associated with either a competent or incompetent urethral sphincter. So, neurogenic bladder is best classified according to the level of the neurological lesion and the resulting pattern of detrusor and urethral sphincter function. So, suprapontine lesions above the pontine micturition center, such as a stroke, Parkinson's disease, traumatic brain injuries, produce detrusor hyperreflexia due to loss of cortical inhibition. So, although involuntary detrusor contractions occur, coordination between the bladder and the external urethral sphincter is preserved, resulting predominantly in storage symptoms, including urgency, frequency, and urgent continence. Suprasacral spinal cord lesions, or these are lesions between the pontine micturition center and the sacral micturition center. These include spinal cord injuries, multiple sclerosis, cervical or thoracic myelopathies, result in detrusor hyperreflexia with detrusor sphincter dyssynergia, And in this condition, involuntary detrusor contractions occur simultaneously with failure of sphincter relaxation, producing high pressure volume, incomplete emptying, reflux, hydronephrosis, and progressive renal impairment. And lastly, we have sacral spinal cord or coracoidal peripheral nerve lesions, which affect S2 to S4. So that's like a diabetic autonomic neuropathy, coracoidal syndrome, pelvic surgery, disc prolapse. These can cause the acontractile detrusor with or without sphincter incompetence. Patients therefore develop chronic urinary retention and overflow incontinence if the sphincter remains competent, whereas denervation of the sphincter leads to stress or continuous urinary incontinence. And this functional classification forms the basic of urodynamic assessments for neurogenic bladder, and it subsequently would affect management. So lastly, let's just touch on a few things that we see regularly as it relates to the extracellular, as it relates to the volume. So let's talk about IV fluids. So IV fluids we know are we used to restore the extracellular fluid volume, they expand extracellular fluid compartment and improve perfusion of tissues. Isotonic fluids like our 0.9% saline or advanced, these remain mainly in the extracellular fluid and are used for intravascular volume replacement hypervolemia. Um, Water moves between the compartments according to osmotic gradients, and sodium is the major determinant of the extracellular fluid osmolality and volume, as you know. IV fluids must maintain appropriate sodium, potassium, and chloride and bicarbonate to preserve cellular function and acid-base homeostasis. Failure of renal regulation or excess IV fluid administration can cause the extracellular fluid compartment to expand, can cause edema, pulmonary congestion, and can cause electrolyte disturbances. Renal failure disrupts the normal extracellular fluid homeostasis because the kidneys are unable to regulate water balance, sodium concentration, electrolyte levels. Reduced glomerular filtration and impaired sodium excretion leads to sodium and water retention, causing expansion of the extracellular fluid compartment with hypertension, peripheral edema, pulmonary edema, and congestive cardiac failure. Damaged nephron loses the ability to concentrate and dilute urine due to impaired tubular function and alters the responsiveness to ADH, resulting in abnormalities of serum osmolality and sodium balance. Um, there'd also be the reduced excretion of electrolytes such as potassium, and that can cause us to get hyperkalemia as well as other um, disturbances. Right. Reduced function also affects the renin, angiotensin, aldosterone system, production of erythropoietin, vitamin D, etc. Right. In shock patients, in shock, there's the failure of adequate tissue perfusion due to reduced circulating volume, impaired cardiac output, and abnormal vascular distribution, loss in extracellular fluid volume, such as via uh, hemorrhagic shock, burns, fluid loss in general is going to decrease the intravascular volume. That is going to decrease venous return, decrease cardiac output, and is going to cause impair organ perfusion and cause organ hypoperfusion. Fluid loss alters sodium and osmolality, causing shifts between the extracellular fluid and intracellular compartments. As compensation, there'd be activation of the sympathetic nervous system, the renin-angiotensin aldosterone system, and the antidiuretic hormones to promote vasoconstriction and sodium and water retention to restore, or to try to restore extracellular fluid volume. In our burns patients, burns disrupt the homeostasis of the extracellular fluid via direct fluid loss, release of the or causing direct fluid loss, activation of the inflammatory response, and increased vascular permeability. Damage to the skin barrier causes loss of plasma, water, and electrolytes from the extracellular compartment, which is then going to cause a decrease in the intravascular volume, decreasing venous return and impaired tissue perfusion. Leaky capillaries, such as via the inflammatory mediators like our histamines and our cytokines, are going to increase capillary permeability, right? It's going to throw off our stalling pressure, stalling forces, plasma proteins and fluids are now going to move from one compartment to the next, move into the interstitial space, cause widespread edema, and further reduce and cause a further reduction in the effective circulating volume that is already compromised in our Burns patient. Um, loss uh, um, Loss of fluid from the extracellular fluid compartment can cause electrolyte abnormalities, can cause sodium and potassium balances, right? And again, in the Burns patient, we're going to have activation of the sympathetic nervous system, activation of our renin and aldosterone, activation of the ADH to try to promote some degree of vasoconstriction and restore fluid volume. And lastly, um, in our surgical patients with regards to post-op care, right? Fluid balance depends on maintaining adequate extracellular fluid volume, electrolyte composition, and tissue perfusion after surgical stress. Um, During surgery, there's fluid losses, blood losses, tooth spaces, drains, the vomiting patients not taking in as much, and that is going to cause a decrease in the extracellular, a depletion of the extracellular fluid, reducing the circulating volume and impairing organ perfusion. The stress response of surgery causes the release of antidiuretic hormone, renin-angiotensin-aldosterone system, causing sodium and water to be retained, which may contribute to, in some cases, a post-op fluid overload edema. There's going to be some degree of altered renal function, IV fluids, um, losses from vomiting, losses from the NG tube causing imbalances in our electrolytes, our sodium, potassium, and our chloride, um, and renal regulation in regards to adequate renal perfusion is responsible for maintaining the homeostasis of the overall fluids and electrolyte um, balance. And post-op oliguria can indicate underlying problems such as hypovolemia, blood loss, renal injury, or obstruction. Right. So that's it. That concludes my presentation on the physiology and formation of urine. These were my main references, the Guyton and Hole and the Costanzo. Yeah.